Okay, so part two. We are actually in the window for our Joint Commission survey. Of course, we are ready for the survey every day, but sometimes it's a good idea to review a couple things to be super duper ready. Our friends in Quality and Patient Safety have prepared a booklet for us with the key points surrounding the survey. We're going to read this book together and focus on the things that pertain to the ICUs. The surveyors will both be asking us for information, but also be observing our practice to make sure that we are doing the things that we are supposed to be doing. If they find discrepancies or issues in our care, they will issue what is called an RFI, which is a requirement for improvement. All of the RFIs will generate action plans, and the institution, will need to show that we are able to correct the deficit either immediately or sometimes within 90 days, depending on the severity of the finding. So no surprise, there will be quite a few topics surrounding medication management. We want to make sure that all medications are labeled appropriately. Opened and unlabeled medications are discarded immediately. Single-dose vials are discarded immediately after use. And multi-dose vials or containers are dated with the expiration date, which is usually 28 days after opening it. Additionally, solutions that are at the bedside need to be labeled and dated, and we all know that saline and sterile water expire 24 hours after opening. If there were any medication errors or near misses, we would want to be able to articulate that those are entered into Quantros within 24 hours. They are reviewed by the management team. There is collaboration with risk management and pharmacy safety committee to review processes and promote safety. Medication storage. So medications are kept in locked cabinets, and the temperature of the med fridge is monitored remotely by a system called AwarePoint. And our friends from pharmacy respond to any out-of-range temperatures. Titration of infusions, so IV drips. The orders must have clear parameters and therapeutic goals, and it's really important that the RN practices within those parameters. Seriously, this is very important. I need everyone to really listen and digest what is going on here. You need to read and pay attention to the details contained in the titration orders for your drips. It's important to understand that the spirit of this measure is to keep patients safe. And the measure was born out of RCAs, multiple RCAs, which reveal that nurses are causing harm by titrating drugs way outside the ordered parameters. And trust me, when you're sitting in front of risk management, the physician is probably not going to say that they were present and ordered that titration. Okay, so we have come such a long way with this situation. We went from 100% non-compliant to really 90% compliant on any given week with the audits that are done by pharmacies. So thank you guys very much. Very, very important to always know what the parameters are and to use the tools that are given to us. So they just implemented the one-time only order change that will cover us when we have to go up or down very quickly. So please use it. Also use the block charting function in Cerner to help you when you have to titrate really quickly. We're going to look at some common titration, and remember that every order is different, the goals are different, and so you need to look at the specific details for your order. Okay, so here's an order for EpiDrip. So the details say that you're going to start at 2 mics per minute. The maximum dose is 5 mics per minute, and the goal for this order is a heart rate of greater than 60. So you're going to titrate up by 2 mics per minute every 15 minutes until that goal is achieved. Okay, so key point is that once the patient is at goal for 2 hours, you need to start decreasing by 1 mic per minute every 2 hours. So this is where we see fallouts. We find that once the patient is at goal, we fail to start titrating the drip down, right? So once you're at goal, we're obligated to start dropping the rate. If your rationale for not titrating down is that the patient is labile, then you need to document some evidence of the patient being labile in the chart. So this is true if the goal is for heart rate or if it's for blood pressure. If it's for blood pressure and you've reached your goal, then you need to show that once stable, you are titrating the drip down. Fentanyl. Okay, so the orders for this drip are to start at 2.5 ml per hour with a goal of CPOT 0 to 2. We have a poorly written order here. We're trying to get it fixed, but the goal could also be vent dysynchrony, shivering, or ICPs greater than 20. So if your patient is bucking the vent, then that would be your goal. I mean, the goal would be for your patient not to be bucking the vent, and you would want to document that. The details of this order say that you're going to assess the CPOT 1 hour after you start the drip, and you're going to assess the CPOT every 4 hours. For a CPOT in this order of 3 to 8, you're going to give a bolus, and then you're going to reassess in 30 minutes after the bolus, and again in 4 hours. So key point again is if you are at goal, it says here for 8 hours, you must start to wean down the fentanyl. And you're going to decrease the fentanyl by 25 mics every 4 hours, and of course reassess. If you continue to document a CPOT of 0 to 2, which is goal, for 8 hours, you must start to decrease. If your argument is that the patient is labile, then again, your documentation needs to reflect that. And one of the most common mistakes that we're seeing is that we're titrating up by 50 mics an hour, and then we're not titrating down again. Norepi or levo. Okay, so here we've got an order to start at 5 mics per minute with a max of 20 mics per minute. So please do not titrate over that max that is set in the parameters. Okay, so then you've got this handy detail that says that you're going to titrate by 2.5 mics per minute every 5 minutes to meet the goal. And you're thinking to yourself, like, are you kidding me? So if you cannot do that, please place a progress note that says that the patient was unstable, that you had to titrate up quicker than the parameters. This is where you would utilize the one-time order. So when you have to jump up or jump down on a drip, you're going to use the one-time order for change. Also, you would have the opportunity to use block charting if you are doing multiple titrations in a short period of time. Once again, once you are at goal, we have to start decreasing the drip by 2.5 mics per minute every 2 hours. If you have some degree of instability, then make sure that you have documentation that shows that instability. Otherwise, the expectation is that you continue to titrate down. And just another point to remember is if you are off of a drip or on minimal drip, and the patient is now requiring you to titrate back up, you really need to let the physician know, because that usually means something bad is happening. Once you've titrated down and you're running at 0 for 4 hours, please discontinue the drip. If you are at 0, please chart 0. Precedex. Okay, this one's pretty messy. So our goal is a RAS 0 to -2, or to control shivering, or for an ICP greater than 20. You're going to assess the RAS 15 minutes after any rate change, and again every 4 hours. For RAS 0 to -2, the goal, you're going to assess the RAS every 4 hours, and if it stays at goal for 8 hours, you must start to drop the drip. If your patient is labile and they really don't stay at goal, then make sure that you're documenting that. So you're going to document like +1, -1 to demonstrate that the patient is just not sitting there at goal. But if your patient is behaving and sitting at goal, 0 to -2, then you're going to start decreasing the drip by 0.1 mic per kilo per hour. So what you really cannot do is go up on sedation when you're documenting that the patient is at goal. If your patient has periods of time when they're jumping under the bed, then make sure that you're documenting, +3, +4. The key is to really document the reality of your patient's condition. So if your patient really isn't just sitting there at goal, then make sure that your documentation reflects that. And of course, what would be really bad, and which does happen, is to be documenting a RAS of -4, -5, and not decreasing the Precedex sedation. Once you're documenting deeper sedation, it's imperative that you start decreasing your drip, and you're going to decrease it by 0.1 mics per kilo per hour reassess in 30 minutes, and then, of course, every 4 hours. So if we thought Precedex was messy, propofol is worse. So for propofol, you're going to have a goal. Here we have a RASS of 0 to -2, or vent dysynchrony, or to control shivering, or for an ICP of greater than 20. You need to know what your goal is. Again, you're going to remember to assess the RASS 15 minutes after any rate change. So rule of thumb, 15 minutes after any rate change. For a RASS of 1 to 4, you're going to increase by 5 mics per kilo per minute only, according to this order. So again, if your patient was jumping under the bed, threatening to pull out their endotracheal tube and all of their lines, you would put a progress note to state that you had to go up on the propofol more or more quickly, and that that a provider was notified or was at the bedside. So again, big deal. If you're documenting for 8 hours straight that you are at goal of 0 to -2, you must start decreasing the propofol by 2.5 mics per kilo per minute every 4 hours. If you have your patient's labile, make sure that your documentation reflects that. Okay, so I'm going to skip over the rest of the drips in that everything is so much better. We are better as a team. Pharmacy has done a great job fixing the orders. The physicians and the MPs have been doing a great job making sure the orders are correct. Just go over a couple little key points again to recap. Please pay attention to all the details of the order. They are very, very specific for what you can do, what you cannot do. If your patient is not stable at the goal, then make sure that you're documenting that. And if you have to titrate outside the parameter, make sure that you are placing a progress note in the chart detailing who was at the bedside and that they were aware of what was going on, and also using that one-time order function that will really help us, and also using block charting wherever appropriate. So drip titration was a big deal on our last survey, and from what we understand, it's also going to be a big deal this survey. Anytime that we are not following the orders, we are technically practicing outside the scope of nursing. So please, this is very serious and we really need to attend to it. Thank you. So moving on, how else do we keep our patients safe? Well, we always, 100% of the time, use the drug library. It's a safety feature of our pumps, and we would always want to make sure that our drugs are dialed in appropriately. And of course, it's always good if the concentration that we're using in the bag matches what we've got on the pump, just saying. So even if it's just IV fluids or Hyperal, please ensure that always we are labeling our pumps. I'm pretty sure you've heard this before, that our number one med error in the unit and all the ICUs is that the concentration in the bag does not actually match the medication that's dialed in on the pump, right? So we're delivering the wrong concentration. And of course, to mitigate this, what we're doing is at S-bar shift handoff, we are validating both the drips and what is left in the bag. Okay, overriding medications. Medications may only be obtained on override for emergent situations where delay may result in clinical harm. Also, the reason for override must be documented and accurate, and so you would not want to choose, say, acute coronary syndrome when you're taking out propofol.